Okay, the last and final session is a question session. So we have questions from the audience and also outside that have been sent in. So we have three panel members. We have Professor Julian Sampson answering genetic questions. We've got Dr. Karen Humphries asking behavioural queries, and lastly Dr. Fiona Brown on dermatology and skin queries. So Sarah, if I can ask you to read some of the external questions first.
Okay, thank you. This is actually a question from a TS parent who has attended the event today. And the question is, my daughter has been on Everolimus for kidney AMLs for about 5 years. What is the current understanding about whether this is a lifetime medication or one that TS patients would stay on for just a period of time?
Julian, will I ask you to respond to that?
Yes, so I mean, this is a really important question. Because tuberous sclerosis is a lifelong condition, I think the expectation is that people who are on Everolimus, provided they don't have too many side effects, should stay on it in the very long term. The Everolimus is really replacing the activity of the TS genes that don't work, and I sort of liken it a little bit to the requirement for someone with diabetes to have extra insulin, or perhaps someone with high blood pressure to have blood pressure tablets. So I think it's probably going to be lifelong. It may be that when people get into older age, the natural history of some TS lesions is to slow down in their growth or even stop. So it may be that in older age, people are going to be able to stop Everolimus. But if side effects are variable, I think the patient should stay on in the long term.
Okay,
Thank you.
Okay, our next question is again from somebody in the audience. And it's, can anyone comment on research into the treatment of protein synthesis with Llysine to prevent, stop or repair facial angiofibromas?
I don't have any experience of it, but I suppose it comes back to what you just mentioned about the Llysine in the diet. But I think this question is about topical Llysine, is it? And I don't have any experience or I'm not aware of any topical Llysine products.
Okay, perhaps that's something to note maybe for us to talk about further. Okay, this is actually a question that we've had from overseas via our internet link up. And this is, if you're a mum and your child has been diagnosed with TS, but you have no symptoms at all and you're 38 years old, can the symptoms come on at this age or later? Even if you've got no symptoms at all now, can you develop LAM, AMLs, or will you never have any problems? And the person who's posted the question has added, genetic tested has provided 10% to 15% risk of no mutation. What is my prognosis?
Okay. So it sounds like this person's child has TS and probably has had an identified TS mutation, and then the parents being tested. That's what it sounds like to me. The 10 to 15% chance of a negative test reflects the sensitivity of these tests in previous times. So we talked about, perhaps 80 to 85 or so % sensitivity of tests, leaving perhaps 15% error rate, if you like. Now that situation has changed, and I think that if this person is concerned about whether they have some significant residual risk for tuberous sclerosis and developing manifestations even at this late stage, they should probably go back to their doctor who did those tests quite some years ago and ask for up-to-date information. But just to reassure this person, I think the chance of any TS manifestations developing at this stage is extremely low. But it would be sensible to go back, because that's what I think the chance is, but it would be crazy for the person not to see a doctor in case they actually have some, say, cutaneous signs now. I think it's very unlikely, but perhaps some up-to-date advice from the doctor who did the test would be a good idea.
Okay, thank you. We have another question here from the father of a 9-year-old TSC patient. Has there been any medical testing of the effect of ECCG, which I believe is a green tea byproduct, on slowing or preventing TS characteristics, for example, angiofibromas, epilepsy, etc.? So the impact of green tea.
Well, can answer this a little bit.
Certainly from a skin point of view, I'm not aware of it.
So so Everolimus and Sirolimus are known to be very effective treatments, but they're quite strong drugs. So these are mTOR inhibitors, and it's known that there are very mild mTOR inhibitors in many other natural products. Actually, Sirolimus is a natural product. Green tea's included in that list. And so people have been looking at whether perhaps some sort of milder dietary supplementation or other forms of mTOR inhibitor might be effective in tuberous sclerosis. On the whole, these haven't actually been tested in patients. They've been tested in cells or in mice. So I'd say things are at a very early stage. And overall, I think it's unlikely that these sort of products are going to have sufficient potency to really impact significantly on tuberous sclerosis. So I wouldn't hold out too much hope, but perhaps more research will tell us eventually that some natural products can have some benefits, but that's not yet the case.
Okay, great, thank you. Julian, this is definitely a question for yourself again, and it refers to your presentation which you gave earlier, and it comes from a member of our TS community in the northeast of England, and it refers to some of the advanced genetic tests that you are now able to carry out. And this lady asks, are these tests now routinely available for children and for parents? And a secondary question is there any progress with stem cell therapy? Okay,
so the TS tests that are offered through the NHS now are very reliable. That is probably 90% sensitive. They can identify a gene change 90% of the time. So if someone had a gene test, for example, 10 or 15 years ago, the sensitivity may have been under 50%. When the tests were first introduced in the NHS, the sensitivity was about 30%. So if someone had a gene test that wasn't revealing many years ago, it's probably worth having another one. These very highly sensitive gene tests that I discussed, they are still in the research domain. They're not yet in the NHS. They're the most sensitive ones that are defining mutations in this previously NMI or no mutation identified group. And I think they'll find their way eventually into the NHS, but at the moment they're too labour intensive. So I think if this person had a test probably more than 10, 15 years ago, and it wasn't helpful, they could go back and ask for a more up-to-date one, but they probably won't get the very whizziest one. And unfortunately, they also won't now get into the research, because actually so many patients have shown an interest in this that we're now full, we can't take any more. In stem cell therapy, it's a very good question. So on the whole, stem cell therapy is being looked at to replace tissues that have been damaged through disease processes, rather than to sort of remove cells that shouldn't be there. But there is evidence that TS lesions like Sagas, for example, develop from stem cells, and so the advances in stem cell therapy might eventually be applicable in tuberous sclerosis. But I'd say at the moment, no, it's drug therapies rather than other types of therapies that are really looking most promising.
Okay, that's great, thank you. A second question as well, I think probably for all of you. It's from the same lady, and she asks, will we be getting Everolimus anytime soon for children? And she makes the comment, she says, it's very hard knowing that there is something out there which is really good and which would help them in many ways, but which we can't always access.
I think it depends exactly for what organ is being looked at. We've certainly tried in our own clinic here to get topical creams for patients, and we've struggled with the financing of that, and we're still working on it. Some of the talks today mentioned the effects on seizures, behaviour, and so on, the kidney effects and the brain effects. So certainly for those licensed conditions, if you're not on a treatment and you'd like to consider that, it's worth considering approaching your own doctor or a local clinic to try that. The different parts of the UK and in Ireland are slightly different in terms of funding, but it's certainly worth going to ask. And I think certainly local pressure where you can is probably the way. People don't like listening sometimes to doctors and medical professionals or health professionals, asking for funding, but sometimes patients can do that much more precisely or engage the help of the TSA to try and do that. So it depends sometimes if that particular questioner wants to come back to us if there's a particular organ in mind, but certainly asking your own local clinic, certainly that should be a felt.
Okay, thank you.
Probably worth just saying something about epilepsy, because I think most parents who have children and are wondering about whether they can get Everolimus, it's in relation to the epilepsy. And of course, in Europe, Everolimus is now licensed for the treatment of epilepsy, not in America, interestingly. But just because it's licensed doesn't mean that the NHS will pay for it. And so, as Patrick says, each bit of the UK, because of devolution, is actually dealing with this situation in a different way. So we're hopeful that in Wales, where we've been in some argument with the government over several months, that funding will be available very soon for the treatment of epilepsy. But it depends where this patient lives. If they're based in England, then in England actually the government has been particularly difficult to convince about the use of Everolimus, and it's taken a few months longer there. But of course it has come through now for brain tumours and for renal AML in England, and I think it will eventually for epilepsy as well. But I think any pressure on MPs, for example, would be very helpful. So if particular patients have issues or particular families have issues, a letter to their MP or going to their MP surgery and explaining the problem would be very helpful.
Okay, fantastic. Thank you very much. We've actually had this question 3 times in slightly different wording, so this is clearly something that is exercising a lot of people. And the question is, if treatment is used effectively for 6 months, and I think that they're referring to Everolimus here, what happens when it's stopped? Do the manifestations of TSC accelerate significantly if it's stopped?
Have you any views from the
Yeah, I think so. I think the answer is yes. You know, if you stop Everolimus treatment, there will be rebound in growth of lesions that have shrunk. They can expand again pretty quickly. The situation in relation to epilepsy, I think, there's little evidence, but what evidence there is also suggests that if you come back off Everolimus having gone on it, that the suppression of seizures, if it has worked, which it does in over half of people, will be reversible pretty quickly. And we've seen the result of stopping Everolimus treatment topically as well. Things come back. We heard about that in Dr. Brown's lecture. So yeah, I think don't come off Everolimus unless the side effects dictate that you must. It would be much better to look at dose reduction. So if you've got some side effects, say you're on 10 milligrams a day, look at going down to 5 milligrams a day. In Wales, we've got patients who are just having 5 milligrams every other day, which seems to be perfectly adequate in some patients for controlling renal AMLs, for example. So if the side effects are bad, try reducing dose.
Yeah, I think it depends why it's been stopped. Some of our speakers earlier referred to their own situations or family members where treatments have been stopped. And as a clinic, we're always keen to continue treatment, but for special indications prior to surgery or other conditions, sometimes the clinicians involved in some of our clinics have no choice in that. It depends on the original indication. So as Julian mentioned, apart from side effects, it's maybe worth going back to whoever prescribed that originally and what the exact reason was. It may have been it was only allocated or funding was for a limited period. So again, we're maybe back to MPs or the clinical reason involved. So it depends on the exact reason for the stopping.
Okay, thank you. Okay, we have a question here which relates to potential malignancy in tumours. So the question goes, in the genetics of TSC, the cell changes develop benign tumours or tubers. What is it that causes benign tumours to become malignant? In other words, can they become malignant tumours? Can things get even worse?
Can you be reassuring?
I think we can be very reassuring here. So cancers related to tuberous sclerosis are rare, very rare. So there is a tiny increase in risk of renal cancer, kidney cancer that is, it's not clear whether those cancers originate always from pre-existing TS lesions, but there does seem to be a small increase in risk. And this can cause trouble when people are having their scans of the kidneys, because it can sometimes be difficult to tell the difference on scan between a kidney cancer and an angiomyolipoma, particularly if there's not much fat there. So what I'd say to people is I wouldn't worry too much at all about the risk of malignancy arising from a TS lesion. The talk I gave, I showed that the TS lesion is very genetically stable, and that's why they don't seem to progress. They grow but remain benign. And if someone has a growth on a scan in the kidney that a doctor tells them is a kidney cancer, they should get a second opinion. They shouldn't agree to have surgery without a second opinion, because it may well not be a cancer.
We have another very simple question here, or maybe it isn't a simple question, I don't know. Does TS make you colourblind? No. Okay, that's a good one. And then we have, I think we have just 3 more, if you bear with me. Okay, we have a question here from, in fact, one of our community speakers earlier today. And the comment is made that the facilities for people with learning disabilities, particularly those learning disabilities with TS in Northern Ireland, are very limited at the moment. So what can we do to change that?
I agree completely that the facilities for people with learning disabilities are very limited, and if there's an additional complexity, they become even more specialised and therefore more limited. Obviously all services are trying to improve, but the only way to improve them is to get the additional resources that are needed, and I'm afraid that comes back to the battering down the doors of your local MPs, MLAs, if we ever get our power ability up and running again, but certainly MPs are the way to go to try and get the additional resources that we need.
Okay. Second to last question. Is there any value for parents getting retested, parents of a child with TSE? Is there any value for those parents getting retested now that science has moved on since perhaps they were first tested 10, 15, maybe 20 years ago?
Do you want to maybe clarify that?
Yeah. So the answer is probably yes. If parents have an affected child, they just have one affected child, and the parents don't have signs or symptoms of TS, the risk that they carry the TS gene is extremely low. But if the test to confirm that was done 10 or 15 years ago, then and after all that time they're madly contemplating having a further child, then perhaps they would like to go and get a more up-to-date test to be absolutely sure. But you know, the risks of carrying the gene are going to be low in anyone who doesn't have signs or symptoms of it. So it's more having a test for reassurance and perhaps having an up-to-date test for additional reassurance rather than any expectation that it will reveal something.
Okay. We've had another question just pop up now from our community saying, please, where can I get topical Everolimus?
Well, I did just text some of my Northern Ireland colleagues, and they have been able to source it through the same sources as the UK from the Nova laboratories, and also through community pharmacy making it up. So I think, again, as Karen alluded to, it's about pressure. And I think if the TSA could put pressure on, this is easily obtainable, you know, albeit unlicensed, and that it is easily obtainable. So I think it just needs a bit of peer pressure.
Okay, thank you.
Yeah, I don't know where this person comes from, but in Wales we've had no success with oral Everolimus, so the tablets, through the IPFR route, which is our individual patient funding request route. So every request we've made for the expensive treatment has been turned down, but every request we've made for the topical Everolimus has been approved. That's because it's not so expensive. You know, it's bizarre because all the randomised controlled trials have been, and the licence is there for the expensive stuff, but it boils down to finance. So if the patient can't get it, then it might be worth trying the IPFR route.
Okay, and our last question is, again from a member of the audience today. how can a person who has been on Everolimus but has suffered some side effects on it and come off it and then been recommended to go back on it at a lower dose, how can the clinicians, how can they manage the risk-benefit scenario? So, in other words, somebody who has been on it, seen some benefits but also seen some drawbacks, has been recommended to go back on it, how can you help them through that process?
Julian, is there a world view on
So,
on it? It's a difficult one.
So, but I think the patient should be able to go back on a reduced dose. The standard dose is 10 milligrams per day. You can measure blood levels, trough blood levels. So most people will take the drug in the morning once a day. So get your doctor to take a level, having missed the tablet that morning, and that gives you a trough level. And I think if someone's had side effects, then the thing to do is to aim for a blood level that is down at the lower end of the therapeutic range. And so we've got quite a lot of patients who are actually on 5 milligrams every other day. So, really a small dose can be adequate for treatment. And so this person should be able to obtain a dose that means they get some benefit without having too many side effects. But some people just do seem to get more side effects, particularly the mouth ulcers. And, if they're really bad, then it may be that you're not going to be able to tolerate any Everolimus. But it's worth trying.
It depends what the side effects were. We've a few patients in our own clinic who've had infections just by chance, and that has tipped them over. So if those infections have been well treated, I suppose whoever's treated the infection might want to offer an opinion to other specialists as to whether they feel that infection has been completely treated and the person can't go back. So again, it depends on why the treatment was stopped.
Okay, that's great. Well, that brings to an end all the questions that we've had within our time frame. So thank you very much.
Okay, thank you very much for those.